I have a microphone. Are you sure? Okay. All right. Hello. My name is Rachel Jalanivich. I'm a doctor of physical therapy. Are we ready, Jenna? Are we doing it? We're thumbs up. Okay. I moved to Lake Stevens earlier this year in May. I was living in San Diego the past 9 years, so everyone cry for me a little this winter. I have a membership to a tanning bed already. Not that I need that, but I'm just very terrified of your winters here. So I moved here. I know, that's what makes me even more scared. So when I moved here, I had been working in clinics in San Diego and doing clinic work for a long time, and I kind of was very burnt out and very tired of seeing 12 to 16 patients a day. I was working with a lot of pelvic trauma, which is very heavy, and I was just not mentally doing well. So I thought that the best thing to do would not be to never work in another clinic again and start my own practice. So I got here and immediately opened Empowered Physical Therapy, which has been amazing. So I'm originally from Livermore, California. I went and wanted to be a physical therapist my whole life since I was 10. I became a personal trainer because, what else is a 17-year-old supposed to do in a small town? And then I had no money for college, so I joined the Navy, and they told me that I couldn't be a physical therapist in the Navy because I wasn't a physical therapist yet. And I was like, well, what can I do to do that? And they said, well, just pick a job for the meantime. You'll submit a package, they'll pick you up, they'll pay for the rest of your school, and then you'll be a physical therapist in the Navy. And I was like, well, that sounds really cool. Give me a job that I can do in the meantime that's really cool, like a once-in-a-lifetime opportunity. They said, well, we have things like rescue swimmer. I was like, what? I know how to swim. That sounds fun. And they were like, cool, there's a $25,000 sign-on bonus. And I was like, yes, sign me up. So I don't know how, but I became a Navy search and rescue swimmer, mostly from stubbornness because I didn't want to quit. And the boys were really mean to me. So I didn't want to show them that I would quit when they were mean. So that was, it was an interesting experience. But I was stationed in Florida and Hawaii. I did a deployment. I did not fight for my flight status when they told me you can't fly with migraines. And I was like, oh, darn, I don't have to do this job? Okay. So I actually got to switch jobs in the Navy, which is hard to do, because when you sign a contract with the government, they got you. So I became a Navy physical therapy assistant. So I went through physical therapy assistant training. I was working in clinics with the Navy. I was running clinics in San Diego as a PT assistant because our PTs quit and we didn't have anyone else, so I was doing it. And so I've been in this physical therapy, personal training, physical fitness world since, a long time. I have a baby face, but I am in my 30s. I got out of the Navy. Yes. Civilian life is way better, let me tell you. And I went on to San Diego. Well, I was living in San Diego. So I stayed in San Diego and got my doctorate degree from San Diego State, and I finished my bachelor's degree there too. I pretty much never wanted to specialize in pelvic floor and women's health. And I was a patient at one point and thought that was just some weird thing they did in the back room. Had no intention of ever learning more about it. But I was leaking and running, and I had never had kids, and I didn't understand why I had pelvic and hip pain when I thought that was just for moms. Like, you guys push something out, that means you guys have to have pelvic floor problems, and I had never pushed something out, so I didn't know why I was having leaking with running and pelvic pain, and I was like, on my worst days, I couldn't walk very well. It was pretty bad. So they sent me to a pelvic floor specialist. I had no intention of wanting to do what she wanted me to do, and I was like, you know what, I'll try it because I'm hurting that bad. So back in the day, I don't know if you've ever been to pelvic floor physical therapy, but they used to just kind of have you do Kegels, and it didn't really work for me, so I just kind of didn't get that much better. I still had a lot of hip pain. I was still leaking with running because, when you're in a horizontal position on a table and all they have you do is Kegel, that doesn't really translate to running and impact activities. So I was kind of a failed patient. So I still was like, no thanks, I have no intention. Give me the people who've got their legs blown off. I want to work with prosthetics, orthotics, amputees. That's what I want. So I was in my doctorate program, and I actually when you're in your doctorate program, you're in a research group. I got assigned to the fecal incontinence research group. super fun learning about anal defecography and it's interesting stuff. Still was like, hard pass, no thanks. Not my future. And then one day, I was sitting around a table with some really smart women. I'm not gonna name them because they would kill me. They were really smart though. They had like master's degrees, doctorate degrees, and these are people that I really have respected and known a long time. And someone said, "Oh, don't make me laugh. You're gonna make me pee." And everyone laughed. And I was like, "Hey, you guys, you know that's not normal, right?" And they were like, "Eye roll. You just wait. You're not a mom yet. You'll be just like us." And I was like, "Oh, shit. This is a systemic issue. These are really smart women. What do the hillbillies think? Like, these are the smart ones. What are we doing? Like, if this is the messaging that's happening in our society, what?" These are really smart women. They should know better. And I was like, oh no, I have to do this. Oh no. And obviously I'm obviously very passionate about it now, but it was definitely it was forced into this. So, what's a pelvic floor? Welcome. So the pelvic floor is this group of, hold on, I've got organs. There we go. This group of muscles and ligaments and connective tissue and nerves that go from pubic bone in the front, sit bones in the bottom where your hamstrings attach, all the way back to your spine, where your attachment sites are at your tailbone, your coccyx. So if you've ever had a fall on your coccyx, you can see how that would really affect everything here. If you've ever had pubic symphysis pain, you can see how that could affect, and you can see inside they kind of horseshoe around and loop together. So when you have pelvic floor issues, it can really impact all these reproductive and bowel organs, all of them. And hopefully your bladder hat doesn't fall off, but that's just in my model. So what does the pelvic floor do? I mean, we know. It supports your organs. It creates some structural support for your skeleton, your pelvic ring. I mean, you can see how it does help provide some support. I mean, not a ton. You've got other muscles that should really be more supporting that. It helps with your pressure management, your pressure canister. It provides some sphincteric closure for, who wants to pee when they don't want to. Then when they don't want to, who wants to poop when they don't want to? Like, this helps. Sexual appreciation, and it helps to circulate some blood and lymphatic fluid through that area. So we kind of touched briefly. I should just ditch the organs. Okay, so since we have our coccyx and our tailbone, we do have some attachment sites to the spine here. So your spinal mechanics, how you move, scoliotic curves, those can all affect your pelvic floor function. So hip and leg, we've got this. I don't have a femur on here, but you all do, I think. I didn't see any people with prosthetics, no? So everyone has a femur. If you have a femur, you have an obturator internus muscle that loops around, and it would attach if I had a femur. Yours attaches onto your leg, which means that your leg biomechanics, your foot biomechanics, things that travel up the chain can affect your pelvic floor. If they're not doing their job, little obturator internus kicks on. He's not supposed to do that job, so then he can't do his own job. So we can have some impacts of your biomechanics from your legs up that impact the pelvic floor too. More relationships, gosh, honestly, anything that attaches to the pelvis, which is like a lot, your whole spine, your spinal, your paraspinals, your deep core, your transverse abdominis, your rectus abdominis, your hamstrings, your lumbar fascia, all of that connects to the spine, and if it's not balanced, it can create torque. And now your pelvis is a very stable structure. These ligaments are really strong. It's never out. Oh, my pelvis is out. No, it's not out. It's there. It's together. But it can kind of get torqued or jammed in a certain direction, and then it's just not as functional. So I don't want you to think that I'm like, oh, you have these very unstable pelvises, and if there's just a little imbalance, you're screwed. You're going to have pelvic floor. No. You have a very stable pelvis, but sometimes things just aren't moving optimally, and that can cause issues. So that was a lot. I understand. That was a lot. I talk fast. Sorry. So everyone, I just want you to do one hand on belly, one hand on chest. Let's take 3 really deep breaths. And as we're breathing, I want you to just notice which hand is moving. Where's your breath going? All right, quiz time. You should have felt the hand on your belly move first and more than the hand on your chest. Now, who's all chest breathers in here? Yeah. Okay, you guys all stressed out. Guess what stress does to your pelvic floor? Just increase. Yeah, we're going to talk about that in a second. So, the relationship to your diaphragm. So you know that your pelvic floor is kind of our base of our pressure management canister. We've got a pressure canister. It's your trunk, right? The top glottis, we can let out pressure here. We have the cans of our pressure canister is your ribs, your lumbar spine, your abs, your core. If you've got a diastasis postpartum, which there's no preventing a diastasis. You all have one at 35, 36 weeks. It's how your body expands to accommodate a growing baby. So there's no preventing it. But, it should start to go back together 3 to 4 to 6 months postpartum. So if we're having pressure leaks anywhere in our system, in our pressure canister, it's a pressure management issue. So the diaphragm and the pelvic floor, they're best friends. They do everything together. If you take deep belly breaths, your diaphragm, how it works, it contracts. It pulls, it creates negative pressure. I don't know how much nerd you want me to speak to you, so I'm gonna try to keep it real simple. But we can go scientifically speaking later if you want. So as your diaphragm contracts, it creates negative pressure, which brings air in. So it should go down, right? Your pelvic floor is best friend. It wants to go down, they want to go together. So we both go down together. So we breathe in, or breathe and inhale, and everything goes down. But you chest breathers, I saw a lot of hands over here, so I don't know what's up with these two tables, but you guys are stressed out. So you chest breathers, you're not getting a lot of diaphragm excursion down, which means your pelvic floor doesn't get to go anywhere. And it's just kind of stuck, and it's not getting as much motion as it would if you were belly breathing. And I say belly breathing because it's got that nice like BB, belly breathing. I really don't want you to only breathe with your belly. I want you to think of it like a 360 breath. Everything should expand when you do a deep breath, a deep diaphragmatic breath. You should feel your low ribs expand. You should feel your pelvic floor lengthen. You should feel everything, including your belly. But just for alliteration's sake, I'm going to call it belly breathing because I can't stop myself. So when you're chest breathing, your pelvic floor is not getting that moment to relax, right? And what do we know about muscles that aren't relaxing? Yeah, they're tight. They're not functional. Like, you can't walk right if you have like a spasmed abdomen. Like, I don't know. Like, it's just, that's a horrible. Can you cut that out of the video? Everyone asks me, what's a Kegel? I don't think I'm Kegling right. Everyone just tells me to do Kegels. I'm like, okay, well, yes, Kegels are a thing. There was definitely like a pendulum, right? Where we didn't know much about pelvic floor, so we just said, everyone do Kegels. And then it made a lot of people worse, right? If you're already tight and tense, and we tell you just keep contracting, keep doing it, it's gonna make it worse. If you're having pain with sex, if you're having vulvar pain, and we keep spasming and contracting around that area, it's going to make them worse. So then the pendulum's swinging the opposite way, and we were like, oh my God, no one do Kegels, ever. Okay, that's kind of wrong too. So we can't really be at either extreme. We have to find a happy medium, because Kegels can be really appropriate for some people. If their pelvic floor is at a normal resting state and it's just kind of weak, Kegels can be a great option. So we talked about, so what is a Kegel? Yeah, it's all these pelvic floor muscles. You can see they're all attached together and they all integrate. So they should be able to contract and kind of lift up towards your head and provide support from below. So if you are feeling it bulge or bear down, or if you're not feeling any movement at all, there's something going on. It should be able to contract and come up towards your head. And if you're, obviously I do this every day with patients and everything. If you're not comfortable self-palpating and feeling if you're doing it correctly, that's fine, I get it. It's awkward. It doesn't have to be, it's your own body. But for some people, you're not comfortable there, that's fine. You can take a towel roll up a towel, sit on it, and take a deep belly breath. See if you feel your pelvic floor, your perineum. Perineum is that area between vagina and anus, that area where everything kind of crisscrosses right here. See if you feel your perineum move. And then try to do a Kegel. See if you feel your perineum come up and away from your towel roll that you're sitting on. And you can kind of test yourself that way. You can also externally palpate to feel if, when I try to do a Kegel, does my perineum lift away from my hand? Does it bulge towards my hand? If it's bulging towards your hand, you're doing it wrong. We're doing the wrong thing. If you don't feel it moving at all, that's a problem. You may be like incredibly weak, or you could be like pre-Kegeled, right? You could be already there, right? And then when you do maybe Kegels wouldn't be the most appropriate for you. How do you know if you have pelvic floor? First of all, can we just talk about how awful a term of pelvic floor dysfunction? Like, if I said you had leg dysfunction, you'd be like, okay, what part of my leg? What's the dysfunction? You know, it's just a really junk umbrella term. So people are like, oh my God, I just got diagnosed with pelvic floor dysfunction. And I'm like, what's the dysfunction? What's going on? You know, like, it's just a junk term just saying that something's not functioning correctly, which you already knew. So if you have difficulty emptying your bladder or bowels, if you have urinary urgency or frequency, if you're accidentally leaking urine or fecal matter, if you have any pain with sex, it should never be painful, ever. If you're having pain with sex, it's not normal at all. If you have a feeling of pelvic heaviness, something kind of falling out, you know that feeling when your tampon's just not like fully in all the way, and it's just kind of like, I don't like that. It's not painful, but it's just, it's uncomfortable. That just without a tampon, if you're feeling like something's kind of just there hanging out, if you have to splint, we call it splinting, in order to have a bowel movement, if you have to like push up on the perineum in order to have a bowel movement, if you have to wake up more than once a night to go pee, if you have frequent UTIs, these are all, if you have hemorrhoids, that's another thing. We have pressure management issues. So, I know, everyone pees and laughs. No. No, common does not mean it's normal. Just because that happens to you does not mean you have to live like that for the rest of your life. So, we kind of talked about this. You know, you already know possible things to this junk terminology of pelvic floor dysfunction. Your biomechanics, so how your foot's moving, how your leg's moving, what are you doing during your day, the pelvic floor muscle relaxation, the strength, the timing, the coordination. Your diet, bowel, and bladder health can play a huge role as well. And we can get into that if you'd like. Stress, mental health, past physical or emotional trauma. Your brain does not know the difference between physical and emotional trauma. If you had any sort of trauma growing up, in your childhood, in your current relationship, in a past relationship, your brain reacted the same way if it was that someone hit you or that someone yelled at you. Your body's gonna react in that fight or flight, sympathetic nervous system activation, stress, increased cortisol, increased pelvic floor contraction. So, why do we leak? I don't know. What's going on? Let's check it out. Is your pelvic floor already contracted? Are you like pre-Kegeled? Is it just that it's like at a normal resting state and it just can't quite contract fast enough, so it's like a timing issue, you've already sneezed and it's too late? Is it just like frankly, like your pelvic floor showed up on time? It was there, it was strong enough, but like you just had so much like rib flexion that your pelvic floor, you created so much extra stress on your pelvic floor that it was like, yeah, sorry man, I did my best, but you just asked too much of me. So is it something else that you're doing? And there's also like another couple reasons here. Like if you knew you had to pee, and you've had to pee for a few hours, and you've just been like not getting off your butt on the couch. I do that. If you've not been getting off your butt and you're just overholding your bladder, and then you sneeze and your pelvic floor is like, look, I showed up, I was here, my bladder's just way too full. Like I can't do that for you. I'm sorry. So why are we leaking? I don't know. We've got to tease these out. This is what I do. I help you tease this out. So as a pelvic floor PT, this is, my little tagline. I help people with pelvic dysfunction. What's dysfunction? I don't know. Something's not going right. Provide holistic strategies to decrease stress and strain on the pelvis so they feel relief. So we'll talk about diet. We'll talk about bladder issues. We'll look at your biomechanics, how you're moving. I personally am a fan of checking it out internally. Let's find out what's going on. Is any of these muscles, there's like 14 different muscles in here. Are any of these tense and tight and tender? Why are we holding tension or tightness or tender, or do we have none? And there's just something else going on. Like, let's figure it out. So, that's my contact information. But a lot of people, this was the whole presentation. And if I get a lot of questions about return to impact postpartum, so I can go there if you want. I get a lot of questions about leaking postpartum. So I made my presentation short so we could ask questions. So, firsthand. Well, okay, so I mean, it could be, for sure. Like, I'm not gonna say it always is, but there's a lot of hip pain and undiagnosed or chronic hip pain that could be actually coming from pelvic floor. I've palpated that obturator internus muscle before, and they're like, oh my God, that's my hip pain. Well, it's not. I mean, yes, it attaches to your hip, but like, this is now a pelvic floor issue. Chronic low back pain is another one that's like, ooh, you know, I've palpated. There's some really interesting, nerdy referral patterns in the pelvic floor that sometimes I'll palpate, and they're like, oh my gosh, that's my back pain. I feel that in my back. And I'm like, well, I'm not on your back at all. But yeah, okay, that checks out. So definitely. Yeah. Next question.
So, 2 children.
Yeah.
Like upper 50s. When I sneeze, if I don't expel, like use the force from here up, then I'm gonna have to take a shower.
Okay.
Is there hope that?
So you are sometimes successful in your sneezing, is that what you're saying?
If I sneeze, I must do it like from here up. Like I can't.
Oh, you do like a short sneeze.
Well, no, actually, it's so violent. It feels like the windows are rattling. I'm doing it.
You're not allowing any excursion.
Right.
Okay, so here's my analogy. So yeah, yes, of course, there's always hope. But I will say there is some consideration to your hormones in your 50s, right? We do start in that perimenopausal phase, which I don't know if you guys know, is actually really similar to your postpartum moment of decreased estrogen in your tissues. So that vaginal dryness is very common when you're postpartum, especially when you're breastfeeding, because your hormones are still wonky at this time. You have decreased estrogen, which decreases your lubrication and your tissue moisture. So, and there is some consideration to the perimenopausal phase of life because, yeah, you do have some drop in estrogen, you have a drop in, but therefore you also have a drop in your, nouns are not always my strong suit, so sometimes I just blank. All right, yeah, collagen. The tissue integrity and the elasticity of the tissues can decrease, and we know that. Like our hands start getting a little bit wrinklier. That, you know, tissues don't like snap back as well. It's the same with your internal organs. So there is some consideration to that, right? But that doesn't mean you. Okay. So, anyways, I had to side note into that. Okay. But when you, if I'm standing here like this, and you say, "Hey, I want you to jump as high as you can," but you can't bend your knees first. Like, okay, like that's not very much power, right? I don't have anything to give. But if you say, okay, you can jump however you want, I just want you to jump as high as you can. Okay, well, I'm gonna bend down, right? I'm gonna lengthen my glutes. I'm gonna stretch the quads, right? And then I have a lot more power to jump higher. So it's the same with your pelvic floor. If you don't allow it to inhale into your belly, lengthen first in order to come up and contract and have power and strength there, you're not gonna have that support from below. And then you have to, I don't know if you can time a recording of your own sneeze and like video yourself, but I bet you're pushing a lot of like, you're hinging here, which can push a lot of pressure down as well. So I would, obviously I need to work on my analogy there because that didn't come across correctly at all. No. So what I would say is similar to that stretch reflex in your glutes when you can lengthen, right? The pelvic floor also has a stretch reflex. It's a muscle, right? When we activate that muscle spindle with the stretch reflex. I told you I could get nerdy. I'm seeing some deer in headlights. I went too nerdy. Okay, I'll bring you back. We need to be able to lengthen in order to contract, okay? So if you're not lengthening, first, if you're just chest breathing first, like sneeze here, right? And did you see I even hinged, even with my fake sneeze? I'm sure it's even worse with a real one. So if you're just breathing here, You're not getting the lengthening to happen before the sneeze. So your pelvic floor is not able to even turn on to help out at all. Of course we're gonna leak. So I would challenge you to, and it's gonna feel really weird. Girl. So during this period of retraining your biomechanics and retraining your bladder, it's like the bladder's a little chihuahua that loves to pee and it's very excited all the time. And it's just like, oh my gosh, I love to pee. I get excited. And if you talk to your chihuahua like, yeah, you want to pee? You want to pee? And he's like, yes. And he's like, okay, I already did it. You're like, okay. But if you talk to your chihuahua like, hey, calm down, sit, stay, I'm the boss. Your chihuahua calms down. Okay. So in this time, like if you've ever trained a dog, you know that there's some accidents that happen in the potty training phase. And if I've got dogs, so I give a lot of dog. But if you train kids, you know there's some accidents, right? There's accidents that happen. So in that time frame, maybe you should wear a panty liner, and that's okay. It's okay to have accidents. We know we're pushing our boundaries, pushing our limits, but still trying to not mentally doom ourselves, right?
That analogy makes a lot of sense to me, and I'm a dog lover.
Okay. Thank you. I'm glad I felt seen there. Okay.
So it's temporary.
Right. So before you take your sneeze, before you take your cough, I don't want you to go this, right? Because then the pelvic floor can't lengthen. And what does this do? Does this actually help anyone? I think everyone. So it actually does help you. That's interesting. Like if I just put all the external pressure I can, and sure, that can help. Right? Yeah, a lot of people do it, but sometimes people still leak with it, so it can't be the only thing. It can't be it. We can't be doomed to this. This is ridiculous. We look ridiculous doing that. It's not. It can't be. But if instead we take that inhale, and I know it feels weird, and it's going to feel weird, but if you go to cough, you usually go up with it. If we go down with the breath instead, so I taught you the belly breathing earlier, I hinted at it. So if we learn how to belly breathe better, and that moment before the cough or the sneeze, if we send our air downwards to allow pelvic floor to lengthen, we may have some accidents while we learn this. That's okay. But if we try really hard, and it is really hard, and it feels very unnatural to inhale downward before a cough, to inhale downward before a sneeze. It feels really weird, and you'll probably look a little weird too. But that's okay if we don't leak. So we're gonna that would be step one. This and it. Okay. Okay. Let me know how it goes. Find me on Instagram or message me or something. I'm curious. Okay, other questions. Sorry, this hand first, then that one. Okay.
I've seen different pelvic floor specialists.
Yeah.
The problem that I seem to come across is that part of my job is fitness, and I have to be in shape.
Yeah.
And after I had my first son, I had DR.
Yeah.
Lower pelvic floor problems, but I didn't know that was an issue, and the exercises that I was required to do made everything worse.
What's up, military?
Made everything worse. And so
Yeah.
the issue that I come across is I would always say, well, what exercises can I do that's not going to make this worse? And how long is it going to take for me to be seen before this can get better? And that always seemed to be the problem for me.
Yeah.
It just seemed like no end in sight. Hey, is this going to be a few months? Is this going to take years? My job requires me to do these exercises. And every pelvic floor specialist I talked to was scared to tell me which exercises I could do or couldn't do.
Yeah. So.
I'm kind of in this yo-yo of I have to do this, but
Yeah, but you don't have to. So you're doing the military PFTs, and they're requiring sit-ups now. Okay.
because they don't have anybody up here
Yeah.
for military in that department,
Yeah.
nobody that can see you for female trauma.
Nope. I think I'm the only one in Lake Stevens who does this, and entirely. And I think that the only military one, and I looked into getting credentialed through TRICARE. They pay very different amounts of money to us in different states, and in California, it was very much worth it to get credentialed. I'm literally losing money if I do it here. And that's like really frustrating because it was actually TRICARE was the only insurance I was actually planning on accepting when I started this company. So I'm mad about it. And I went through the whole thing. I think I actually did get credentialed, but I can't afford to see TRICARE patients unless I'm doing what clinics do and seeing 2 an hour. So you get 30 minutes or you get handed off to an aide. And it's just like, it's not long enough. I can't even get your pants off and tell you all this stuff in that time. Like, I can't do it. It's very frustrating for me too. And as a veteran, I hate it, but I just kind of hate the whole insurance game. I'm going to use my hair tie analogy for you. So when we're pregnant, the linea alba down the center of your six-pack. Yes, you all have a six-pack. You got those washboard abs. You just might have some laundry on top. And that's okay, but you all have it. So if we've got that stretching horizontally that happens, which it will and it does, and you're postpartum only a few months right now, right? Or has this been... Yeah, I was like, I have no idea. That baby looks very large to me. So you're only a few weeks. So give yourself some grace here. And I think for the military, which branch are you in?
Army.
And so they have to do sit-ups and push-ups and not pull-ups. Okay.
It used to be that, and so after I had my first son, I basically was like, the person that did just push-ups, sit-ups, and running and all this other
Yeah.
stuff to try to maintain that. But the sit-ups, like...
The sit-ups are not a great option.
Like, I really struggled. Like, I went to, when I was like 4 months postpartum, I went to a boot camp, and the lady wanted us to, like, put our hands on the sliders and slide up.
Oh, no. Oh, no. Those are great exercises, don't get me wrong, but I wouldn't go there first for you.
I collapsed on the floor, and she's like,
She just couldn't understand.
contract your abdominal muscles.
You're like, I don't even know where those are right now. They're, yeah. Okay. So,
All my grandmas survived physically through the military over the years, and now I'm postpartum again.
and we never healed from the first one.
No.
Yeah, so like it compounds. It's not easier now, which is why you should all see me before things get worse. Okay, so shameless plug. All right, so if you stretched horizontally during pregnancy to round belly, and there's some like lengthening, stretching too, but my analogy works best with the horizontal, so we're going with that. All right, so if you get the horizontal stretching during pregnancy, and then great, okay, maybe it's back to here postpartum. What do we do, like sit-ups? No, that doesn't close that gap, right? How do we close the gap? Like rotational work can help a little, but like part of it gets tension while part of it gets approximated. Meh. I don't know how nerdy you guys are, but Wolff's law, Wolff was a physicist who did I think he was a physicist, don't quote me on that. It's a physics rule. So he said that all tissues in the body will strengthen in the way they are demanded to strengthen. So if we have tension this way, we need to start tension this way to close it, right? So that's a lot of overhead work. So you have a baby, great, play with it. Work on that deceleration, right? You can work on a lot of, first of all, and I will say, you do not have to close the diastasis passively as long as you can control it functionally, right? It doesn't mean like, what I mean when I say control, and for everyone that doesn't know what a diastasis is, it's that separation of your abdominal muscles. You get like a bulging, a coning, a doming, whatever terminology you care to use. It looks like you could still be pregnant because you have this bulging happening here. So when we're pushing pressure, and it's a pressure management issue as well, right? So when we're pushing pressure here, well, what's going on at your lumbar spine? Are we extending a bunch? Are we putting a ton of pressure back here, which forces even more? Like I like to work on a lot of fascial work on lumbar spine because it tends to be really tight with DR. I like to work on a little bit of, that deep core work and stability, but you have to get overhead, because that's the only way to tension it vertically. And when people ask me, like, how long is this going to take to heal? I said, how good of a patient are you? Right? I don't know, right? So like typically, I can say typically, but that's for people who are very good about doing their homework that I ask them to do, not doing the things we tell them not to do. Like it's hard to say, and everyone does have a different healing timeline. You know, nutrition plays a role in that. Your lifestyle plays a role. If you keep doing the things that tension it horizontally, like sit-ups, it's going to take longer. So yes, I can typically get people healed with diastasis in like 5-ish months. It is a ligament, right? So it's not something that heals very quickly like a muscle because it has less vascularization and blood flow. So it does take some time, but if you can control it functionally, even if you passively still have like a 3-finger width gap or something, if you can do the thing you need to do and get the good closure, then that passive ligamentous laxity isn't as big of an issue. So if we can, and I will also say, because of Wolff's Law, we should be training you to do the things you have to do for your job. But we can make them easier and easier to the point where you can control it functionally and then make it harder and harder and harder and harder until you can do the thing you need to do for your job. There was a lot of words there. I don't know if any of those translated. Okay, I know. It's frustrating. Oh, yeah. Well, it's not like we can go and be like, what you doing over there? Hey, come feel this. Right? Like, we all end up being a little different because we're all treating in private rooms typically, right? So I can't be like, hey, that thing that you were doing with that patient internally, can you show me that at lunch? Like I could with a knee pain patient. Like, hey, I saw you doing that knee mob on that patient over there. Can you show me at lunchtime? Like, we don't see what other people are doing, so we do tend to be very different. Again, I also came from a patient background where it didn't help me. And I'm like a failed patient, so I wanted to be better. And I did do a lot of outpatient ortho work prior to becoming a pelvic PT. So I do look at things maybe differently than someone who just went straight out of school and went to like get their pelvic PT classes. And so, yeah, we are all different. And it is a very intimate thing that is kind of weird, and we can acknowledge that it's weird and still say, yeah, but it works. And if the personality match isn't there either, that's a factor. Like if I'm weird, so if I'm like little, so if the personality match isn't there, like you need a different pelvic PT. Like you can't heal when you don't feel safe, and if somebody isn't making you feel safe, then it's not a good match. Yeah, and unfortunately, there's just not a ton here. So it's not like it's hard to be picky. First of all, we don't use speculums.
Right. But
What?
women can be super tense during
Oh, yeah.
examination.
Well, we don't do speculums. Okay. I'm nicer than an OB. There's not even stirrups. So but yeah. I was like, we need to work on some breath work over here. Okay, I think other question, yeah. Yeah.
Like the first couple weeks or first couple months after.
Oh, yeah, easily. So that belly breathing we did, I know it seems really basic and simple, but that is like my number one. I mean, no matter what pelvic PT you go to, I'm pretty sure, I don't know, you can prove me wrong here, they're always going to talk to you about how you breathe.
They have.
Yes! Okay, I was right.
The difference between mine is some of my pelvic floor PTs did like internal.
Mm-hmm. And some didn't. Yeah.
Some did not at all. And I'm like sitting there like, wait a minute. Like I know from this
Other one.
issues internally, but you're telling me you're only going to focus on the outside. So that's where there were like this kind of conflicts, and then the exercises they're telling me to do. I'm like, wait a minute. The last lady told me not to do that.
Well, and I will say there is like a timeline of like, hey, like I know you couldn't do this a few months ago, but now you can, right? And so maybe I don't know. I don't want to like poo-poo on them. I don't want to poo-poo on them, but like, and there's a consideration to timeline. Like, hey, right now sit-ups aren't great. Like, let's not do them. But like in a few months, sure, let's progress towards that if you need to do that for your job. But for now, let's do this other thing. And part of the downside of seeing patients for only 30 minutes is you don't have time to explain that. And you don't have time to educate and empower them, right? Because, yeah. So you don't have time to do that because you're so rushed, or you see them for 45 minutes, but you're kicking them out the door at 40 because you got to do the note. Yeah. So I feel you. But the best things that they can do postpartum, and you guys, don't have like a table up here for me to like here we go. So postpartum, a few weeks, right? We can be hands and knees. We can be doing spinal mobility. We can be doing breath work. We can do side-to-side wiggling, right? All these things should be safe for you to do. Doing your belly breaths, just kind of feeling your pelvic floor move a little bit. Don't even try to Kegel quite yet. It's just we're working on the belly breaths. The diaphragm, pelvic floor go together, right? You can be doing some rotational work, working on your thoracic spine. I know look at that hunching that's happening, right? You can work on stretching your chest, getting some rotation up and over. We can do all these very gentle yoga-ish things that aren't creating, and that first 5 days postpartum, you should really just be hanging out in bed. Yep, just in bed. The next 5 days, maybe around the bed. Like, don't be going for a walk at day 10. We're not there yet, and it's just slowly. And I know that they say, 6 weeks, you're cleared to run, you're cleared to have sex, go do it. And you're like, whoa, what? I haven't run in a while. I haven't done this kind of stuff in a minute. And everyone's timeline is different, especially C-sections. That uterine lining that they cut through to get your baby out is only like 50% healed at 6 weeks postpartum. So like, no, maybe, how about not? Like, if you want to return to run, what if we just like bounce first, right? What if we just bounce on one leg first, right? Because what is running but a series of like single leg jumping? If you can't even single leg jump without leaking, you should not be going for a run yet. Like we're not ready. If you want to get back into doing, jumping jacks for, military stuff, and I see people just like, hey, I'm going to go learn how to do jumping jacks or jump rope today. I want to go to the jump park with my kids. I'm just going to start jumping. Well, maybe we could just start with like this. Or, this, right? We can progress gradually to, okay. We can start progressing a little bit more gradually into those things. If you want to go back to running, but you leak, okay, well, what if running kind of looks like mountain climbers. And I don't know if you guys know what mountain climbers are, but I know my military people do. So if you do mountain climbers, but to a surface that's higher, that kind of looks like running. So we're starting to train the pelvic floor for impact. And as long as you're not leaking, and that's how I define success, right, is you're not leaking in this position. If you're leaking, you've done too much. Your pelvic floor is compensating by leaking. So you can do something at a different level that is still similar to what you want to do, but that's where we're at for now. And maybe in a week or two, we can make it harder. Make it look more like running or more like the activity you want it to look like. These are long-winded answers. Yes?
So if I go to a pelvic floor therapist, I can expect him not to be wearing pants.
The whole time, I'm just gonna, no.
You did take off your pants. I didn't realize that at all.
So, first of all, consent is very important. So I'm not taking off anybody's pants. I hope that came across. Okay. We do internal work, and again, I know that we've kind of already learned that maybe not all pelvic PTs do that. And I will say it's not required, right? I don't have to touch the inside to kind of maybe listen to your story, listen to your symptoms, palpate a little externally, see how you're moving, and be like, hey, I think this is what's going on. I don't know for sure, but I think this is what's going on. Let's start treating you for that problem that we think, and then if we plateau, we can have that conversation again of like, hey, we plateaued, we're not going down the right road here, maybe we should find out more information. Are you open to doing an internal exam now? And that's okay. But if we really want to find out, like I have some CrossFitters who get some issues with their deep squats, and I will palpate their pelvic floor while they're doing a deep squat. Like, well, let's get it. Let's put the robe on. Let's pin it, like, let's do this, girl. Like, let's find out what your pelvic floor is doing in that deep squat if that's the issue. Like, why wouldn't we make it functional? Why? Because you laying on your back on a table is not where you're telling me you're leaking. So it's not always the best indicator of what's happening.
I also heard you talk about like menopausal hormonal stuff. Like I noticed like before my period, I can feel like kind of leaky.
Yeah. Yeah, there's some like uterine heaviness that happens around that time, right? Like the uterine wall's bulking up to prepare your body for another baby. And you're like, no, let's not right now, thanks. Let's shed that instead. But around that time, there is some increased ligamentous laxity as well. So during that time, it's okay to take things a little easier on your body and in your workouts. If it's just happening with sneezing and coughing, like that's, maybe an indicator that something dysfunctional is happening. Oh, let's find out what's going on. Does that answer? Okay. Yes. I love seeing people at 2 weeks postpartum. And obviously we're not doing internal work at that point, because if a penis hasn't been cleared to go there, I'm also not going there. Yeah. Gotta release it. Yeah. I mean, if you came in with like foot pain and someone just kind of like, looks good. Yeah, wiggle it a little. Okay. Yeah, here's what we're gonna do. And like they never touched your foot. Like, of course, yeah, internal work is like kind of, yeah, yeah. No, and I think I know the clinic. And they're great. Yeah, and it is weird. Like, we can acknowledge it's weird. Yep, totally. Yep. Again, and if we don't make it weird, and it's probably not, don't make it weird. Yeah, same. Same. And I think I do have the ability to make really weird topics a little less uncomfortable. And, it's a skill of mine. It's been developed over some years. But listen, I was always the girl who was like, I gotta go poop, guys. Bye. And like, I was always that girl. So maybe I've always been destined for this job, even though I didn't want it. So postpartum at a couple weeks, I like seeing people because you're already picking up an 8, 10, 15-pound thing, right? And if you're picking it up wrong, you can be causing prolapses, and nobody wants prolapses. So if we can prevent prolapse by just, hey, let's come in, let's look at how you're moving, let's look at how you're breathing, let's teach you some like good nursing strategies so you don't come into me with neck pain in a month or two and shoulder pain. And everyone who carries their babe, because most people right-handed, so everyone carries on left. And then like, I don't know why my left back hurts. Like, okay, well, have we tried switching arms with this 15, 20, 40-pound thing that you're holding for hours? Like, gosh, we got to switch sides. We got to work on the symmetry and decreasing the stress and strain around the muscles that pull on the pelvis, that pull things out of whack. I do. Oh my gosh. And I even, for the pregnant people, I even train into different birthing positionings. We talk about as the pelvic inlet, how it needs to move when the baby's at the pelvic inlet versus the mid-pelvis with that ring versus the pelvic outlet when the baby's passing through the pelvis in those different ways, like the different birthing positions that can be helpful in those moments, which, even if you have an epidural, we should still be able to practice certain motions that could help you. But yeah, I definitely, I do see a few complications post-epidurals. I mean, they're gonna have an increased risk of tearing. They're gonna have an increased risk of long labor, low back pain from the epidural puncture, some stuff like that. So I do like to help coach people if they want a natural birth. I love pushing for that for them. And yeah. Yeah, so I know I get a lot of questions about insurance and stuff. So I am cash pay. I can provide super bills. I can do HSA cards. And I know there's only a month left in the year to use those, so use them up, right? Because that's ridiculous. Use them. So I can do that. They're like cards that like people pay into throughout the year, and then you can just swipe it, like boom, swiped, paid for my massage, boom, swiped, paid for pelvic PT. It's pretty cool. It's only certain insurance. I don't understand insurance. I'm not doing it. But yeah, or if people have out-of-network benefits, they can submit and they can request a super bill, which is essentially just a receipt that you paid that your insurance should pay you back. And sometimes they pay. I can give you super bills. Yeah. Hopefully. Hopefully. I hope so. And sometimes they'll give 100% back. Sometimes they'll give 80, 60, 40. I don't know. It just depends on your coverage and and if I write them wrong or whatever, if the insurance doesn't reimburse for something that I did, I'm happy to rewrite them. Like, it's not that difficult. Yeah, that's nice. And all my pricing is on my website. I'm very transparent. But for you guys today, so I do charge $155 initial eval, $125 follow-ups. But if you guys want and were here today or you watch on the replay, message me about it and be like, hey, I watched you on the replay. You said I could get this for $97 for my initial eval. And I'll be like, darn, okay, they caught me. No, I'm happy to give you guys that discount. I know I'm running an ad right now and they're offering that same deal. So if you see my Facebook ads or Instagram ads, algorithms got you. And you guys, it's the same deal. So you can just message me about it too. So yeah, there are more questions. I know there's more questions. A mile from here. So I treat out of my house. So there's a really awkward space in my house with a private entrance, and it was horrible for a bedroom, but I was like, hold on, I'm starting my own business. And a lot of patients don't want to be seen in their homes because they're like, I have a crazy dog, my husband works from home, it's chaos there, please let me come to you. And I'm like, sweet, here's my clinic space. It's a really awkward bedroom, but it's a perfect clinic space. There's a video of it on Instagram if anyone wants to look at it before they come or something. I can't offer me being mobile to you for my my deal because gas, and I drive an SUV. So, but I can, for subsequent visits, we can talk about like if you're in my radius where I can hit mobile visits, I can offer that too. And those are great for postpartum, especially as you got kids and you don't want to do the daycare thing or find childcare or whatever. So I am able to be mobile. I just can't offer it on the like $97 deal. Yeah. My clinic is like super not kid friendly. But again, if the initial eval, if you want to come to me for the deal, and then if you want me to come to you, and if you're in my I try to stay within like a 20-minute drive range of my clinic space so I can make it back on time for the next person. But they can be there. Kids are there and they exist, and we just do our best to make them less because we want it to be about you, right? We can sit there and play with the kid, but that's not why you're paying me, right? I'd rather focus on you. So we'll just work together to figure out a strategy to decrease the disruption. Yeah.
How do hemorrhoids relate to 10 years and nobody's said a thing about pelvic floor?
Well, it could be dietary, right? If you're straining to poop, and I know that normal pooping is qualified as 3 times a day to once a week, and that I'm gonna stand here and be like, no, get out. You should poop once a day. It should be like a ripe banana, no Cocoa Pebbles, no stew. It should be a ripe banana. If you're pooping every single day ripe banana, then I'll agree you're not constipated. But every patient is all constipated until proven otherwise. I don't believe you guys. You're always constipated, especially if you have pelvic floor tension, because the rectum goes through the pelvic floor and, right? Yeah, okay, we got the visual. All right, so those muscles loop around the back of the rectum. See how it's got a corner? It's like you're pooping around a 90-degree angle. And when those muscles are tense, that it kinks the hose. Try to poop through a squished off lawn hose. Like, it doesn't work so well. And you have to strain harder, and that pressure downwards, where's the pressure gonna go? These little blood vessels are like, bleep, me, okay? Yeah, so, and if you've ever had a hemorrhoid, even if the little blood vessel isn't in there anymore, you still got your little pocket. It's still ready. It'll be ready for when you come back. No, so we've got to work squatty potties. Everybody should have a squatty potty. You don't have to doom yourself to the really ugly white ones. I bought like a really cute bamboo one with like foot rollers to give myself a little foot massage. Getting the it's a little bougie, but it was on sale. I think it was Black Friday. Hey, so you guys should get yourself a squatty potty. Anything. It doesn't have to be a squatty potty. It could be an upside down bucket. It could be your kid's step stool. Anything that gets your knees above your hips will lengthen those muscles so they don't sling around the bottom of the rectum so hard and lessen this curve. So that's that. And then we talk about dietary considerations. Always more vegetables would be a good option. If it is a constipation issue, veggies and magnesium citrate is a really good stool softener. I will fight anyone who says that Miralax is good for you, because it's not. It's not. Yeah, I will literally fight them. Magnesium citrate for poop, magnesium glycinate for muscle relaxing at night would be a really good option for you guys to sleep a little bit better. But magnesium citrate is going to be your option for better poops. Calm is great. Yeah, it's not magnesium citrate in there, but there's a cool chemical process that changes it into magnesium citrate in your body, so it's basically magnesium citrate. Yeah. Yeah. More questions? All right. You guys can message me. I'm available for questions. I also offer like a free 15-minute consult. Like, we can do phone call. We can hop on a video chat. I ain't afraid. I'll show you my face. Like, let's do it. Let's talk about what's going on. We can talk about like the ways I would help you and how to move forward from there. Give you a few tips, like so, and see if you even need me. Because if I can give you a tip and you don't even need me, like, I'm obviously the worst business person in the history of ever, but I'd rather you just be better and go tell other people, like, oh my gosh, go call this girl, right? Like, it's an abundance mindset, right? Like, I'm not here to like hoard all the patients, like keep them forever. Like, no, go fix yourself. Take this tool, fix yourself, get out. Like, go be better. There's more patients than I could possibly treat. So, anybody else? All right. I don't know how to turn this off.